Picture this. It's 3 o'clock in the morning in A&E.
Oh, we've all been there.
Right. You have a patient sitting on the edge of the bed, and they are clutching their arm to their chest in absolute 10 out of 10 agony.
Sweating, usually.
Sweating, panicking. They're guarding the joint so fiercely you cannot even get near it to examine them.
You can't even touch the skin.
Exactly. And every instant you have as a clinician is screaming that you're looking at an acute septic joint or maybe a massive, catastrophic, acute cuff tear.
It looks like a disaster.
It really does. But the reality, that excruciating, blinding pain, is actually the exact moment their body is spontaneously healing itself.
It's an incredible paradox.
It is. Welcome to Deep Dive Ortho. Today, we are decoding the pathophysiology and the treatment algorithm for calcific tendinitis of the shoulder.
It's a topic that really defies standard MSK logic, doesn't it?
Completely. And to help us navigate all this landmark literature and build a robust, evidence-based clinical framework, I am joined today by Professor Mo Imam, a leading authority on shoulder surgery.
It's great to be here to get into the weeds on this.
And if you are an orthopedic trainee, a shoulder surgeon, a physiotherapist, or a GP with a musculoskeletal interest, this deep dive is for you. We're leaving the basic textbook definitions behind today.
Yeah, we're getting straight into high-level clinical decision-making.
So let's drop right into the deep end with that patient in A&E, the paradox of pain.
The acute resorptive crisis.
Right. When a patient is presenting with that hyperacute, immobilizing pain, what is actually happening at a cellular level? Because it seems so disproportionately severe compared to, say, a standard tendinopathy.
Well, to understand the crisis, you really have to zoom in on the microenvironment of the rotator cuff tendon.
Okay.
Prior to this exact moment, the calcium deposit has just been sitting there, relatively inert.
Just hanging out.
Exactly, doing nothing.
Yeah.
But suddenly, the body's immune system wakes up. It recognizes this massive deposit of calcium carbonate apatite not as a structural part of the tendon, but as a foreign body.
Like a splinter.
Like a massive internal splinter. And it triggers a massive, overwhelming inflammatory cascade. You get this profound vascular ingrowth into an area of the tendon that is usually, well, quite avascular.
Right, the critical zone.
Spot on. So blood vessels rush in and macrophages and multinucleated giant cells just flood the zone.
And their entire job is to, what, phagocytose the calcium?
Yes. They're essentially swarming the deposit to eat it.
Okay, but surely the simple presence of macrophages doesn't cause a patient to lose sleep for 3 days straight. I mean, we have macrophages working all over our bodies.
True, but it's the byproducts of that cellular feast that cause the agony.
The byproduct.
Yeah. Firstly, you have severe chemical irritation.
Yeah.
These macrophages are releasing a literal storm of inflammatory cytokines.
Like interleukins.
Interleukins, tumor necrosis factor, you name it. And they're releasing it right into the confined space beneath the coracoacromial arch.
Which is already a tight space.
Exactly. That chemical soup sensitizes the local nerve endings to an extreme degree. But secondly, and honestly perhaps more importantly, is the mechanical factor.
Okay, walk me through the mechanical side.
As the solid calcium is broken down by the enzymes, it actually changes state. It turns from a hard chalk into a thick, milky, toothpaste-like exudate.
Oh, wow. So it literally liquefies.
It does, and that exudate is highly hydrophilic.
Meaning it draws in water.
Exactly. It absorbs fluid from all the surrounding inflamed tissue. So you have this rapidly expanding volume of liquid trapped within the tight, unyielding collagen fibers of the supraspinatus tendon.
So the pressure just skyrockets.
The intratendinous pressure goes through the roof, the tendon swells massively, so every time the patient even twitches their arm, that swollen, hypersensitized tendon is being mechanically crushed against the acromion above it.
So it's a double hit. Severe chemical inflammation coupled with acute mechanical, almost compartment-like pressure.
Exactly. It's a perfect storm of pain.
It's rather like a fever breaking, isn't it? The body's inflammatory response is operating at maximum intensity to clear the threat, meaning the loudest alarm sounds just as the danger is passing.
That's a brilliant way to phrase it, yeah.
But practically speaking, if you have a patient in front of you who is in tears and they are begging for you to just fix it.
Which they will do.
Right. How do you navigate that conversation? Because telling someone in 10 out of 10 pain to just wait it out because their body is doing a great job, that feels like a fantastic way to get a complaint filed against you.
It really is the crux of the clinical challenge.
Yeah.
In this scenario, communication is a clinical intervention in itself.
You can't just brush it off.
No, absolutely not. You cannot just dismiss the pain as, part of the process, you have to aggressively validate their suffering.
What do you actually say to them?
I'll sit down, look them in the eye, and say, the pain you are experiencing right now is equivalent to a severe fracture or a deep bone infection. I believe you.
Validation first.
Always. But then you immediately reframe the pathology. I explain that their body is successfully performing a biological operation to remove a calcium stone from their tendon.
That's a great analogy, a biological operation.
Yeah, and I tell them, if I were to take you to theater right now and cut into that hyperinflamed, friable tissue, I would be interrupting the body just as it's finishing the job.
And what would be the consequence of that?
I would likely leave them with a profoundly stiff shoulder, a frozen shoulder, for a year.
Right, so you're dealing with a self-limiting condition, but the symptoms are not self-limiting in the short term.
Exactly.
So what is the pharmacological bridge here? How do we actually get them through those crucial days or maybe weeks without intervening surgically?
The management priority in that specific hyperacute presentation is urgently dialing down the symptoms. You hit them with potent, short courses of NSAIDs if they can tolerate them.
Like indomethacin.
Yeah, indomethacin or naproxen rather than just over-the-counter ibuprofen. You need something with a real kick.
You optimize their baseline analgesia.
Right. And crucially, if the pain is completely unmanageable, a targeted subacromial steroid injection can be the circuit breaker.
Okay, let's pause on the steroid injection for a second.
Sure.
If the macrophages and the inflammatory cytokines are the very tools the body is using to dissolve the calcium, and we inject a potent corticosteroid, which is a profound immunosuppressant, are we not just hitting the pause button on the healing process?
It's a very fair question.
I mean, are we stopping the pain but trapping the patient in the resorptive phase?
It's an incredibly astute biological concern, and honestly, it's heavily debated in the literature.
So what's a consensus?
The evidence suggests it's a matter of anatomical placement and timing. You see, you are not trying to inject the steroid directly into the intratendinous calcium deposit to stop the macrophages.
You're aiming higher.
Exactly. You are injecting it into the subacromial bursa, which is lying just above the tendon.
And that bursa is secondarily inflamed by the bulging tendon beneath it.
Spot on. The bursitis is actually causing a massive proportion of the pain.
Oh, I see.
By dampening the bursal inflammation, you give the patient enough of a window of relief to sleep, to move the arm gently, while the intratendinous phagocytosis continues underneath.
That makes a lot of sense. You quiet the bursa, but let the tendon do its work.
Exactly. That said, you have to use them judiciously. Multiple, repeated steroid injections might indeed interfere with the natural history of the disease by inhibiting that necessary vascular proliferation.
Right. 1 is a circuit breaker, 3 is a roadblock.
Perfectly put.
So contrast that hyperacute screaming in A&E presentation with, say, a patient who wanders into your clinic with a dull chronic ache.
A completely different beast.
Yeah, they've had impingement-like symptoms for 8 months. They can't quite reach into the backseat of the car without a twinge.
Entirely different clinical picture.
Yeah.
That patient is likely in the formative or resting phase of the disease.
So the calcium is different.
Yeah, the calcium is a hard, chalky mass embedded in the tendon. It is actively altering the biomechanics of the rotator cuff.
Effectively creating a space-occupying lesion.
Exactly, which causes mechanical impingement, but it's not actively inflamed. The body is effectively ignoring it.
So how does the management change?
That patient requires a much more proactive, stepwise interventional algorithm because their body isn't actively trying to clear the deposit.
Which perfectly transitions us into the biological clockwork of this disease. To truly understand why some patients have a dull ache and others have an acute crisis, we need to rewind the clock.
We have to look at the entire life cycle.
Exactly. We're talking about Uthoff's landmark life cycle model from the beginning.
H.K. Uthoff's histological studies from the 70s and 80s completely rewrote our understanding of this condition.
Because prior to his work, what did people think it was?
The prevailing dogma was that calcific tendinitis was just end-stage degenerative wear and tear.
Like osteoarthritis of the tendon.
Exactly, a one-way street of tendon death. But Uthoff proved that it is a dynamic, cell-mediated, and ultimately reversible process.
He broke it down into 3 distinct phases, right? The precalcific, the calcific, and the postcalcific phases.
Yes, and within that middle calcific phase, we have the formative and resorptive stages.
Let's start at ground zero. What is the genesis of this disease in the precalcific phase?
Well, the precalcific phase is entirely asymptomatic. You would never know what's happening.
So the patient feels nothing.
Nothing at all. At the cellular level, the tenocytes, Those are the highly specialized fibroblasts that maintain normal tendon collagen. They undergo what we call fibrocartilaginous metaplasia.
Metaplasia, meaning they fundamentally change their cellular identity.
Exactly. They transform from tendon cells into chondrocytes, which are cartilage-producing cells.
Wait, hold on. Why on earth would a normal, healthy tendon cell suddenly decide it needs to become a cartilage cell? What's the trigger for that identity crisis?
The primary culprit is believed to be localized tissue hypoxia.
Lack of oxygen.
Yeah, lack of oxygen, often combined with mechanical microtrauma. If you look at the anatomy of the supraspinatus tendon, there's a well-documented hypovascular area, roughly 1 centimeter proximal to its insertion on the greater tuberosity.
The critical zone of Codman.
The critical zone, yes. When you abduct your arm, the vessels supplying this area are mechanically wrung out over the humeral head, creating transient ischemia.
Like wringing out a sponge.
Exactly like that. Now, if the patient has slightly altered scapular biomechanics, or maybe they do repetitive overhead strain, that transient ischemia becomes chronic cellular stress.
So the cells are literally starving for oxygen.
Yes. And as a survival mechanism, the tenocytes shift away from their normal aerobic metabolism.
Because cartilage cells don't need as much oxygen.
Right. Cartilage cells are far better equipped to survive in a low-oxygen, high-pressure environment than tendon cells are.
Wow.
So local growth factors are upregulated, gene transcription changes, and the tissue transforms into fibrocartilage. It's a biological adaptation to a hostile microenvironment.
That makes perfect sense biologically. So now we have this patch of cartilage living inside a tendon. We enter the calcific phase, specifically the formative stage. Yeah. What are those new chondrocytes doing?
They do what cartilage cells are programmed to do. They start secreting a matrix, and then they mediate the deposition of calcium crystals.
Specifically carbonate apatite.
Yes, carbonate apatite right into that extracellular matrix. They are actively constructing a rock inside the tendon.
But here is what I struggle to conceptualize. If the body is actively building a physical mass of calcium right inside a major load-bearing tendon, how is that phase comparatively silent?
It seems counterintuitive, doesn't it?
Completely. Shouldn't a growing rock in your shoulder trigger massive alarm bells?
You would think so, but it comes down to the absence of blood vessels and acute inflammatory cells.
Because it's in that critical zone.
Exactly.
Yeah.
This construction is happening in that hypoxic avascular zone. Because there is no rich capillary network feeding the area, there's no route for inflammatory cytokines or pain-mediating immune cells to access the site.
So the immune system is literally blind to it.
It simply does not see the calcium as an acute biochemical threat yet. It's essentially a silent construction site.
The workers are building this dense mass of calcium, but they are doing it quietly in the dark without pulling the fire alarm.
Perfect analogy.
So the pain they do feel, that chronic dull ache we mentioned earlier, is purely mechanical.
Yes, entirely. The tendon becomes physically thicker because of the internal mass. It loses its elasticity.
Right.
So when the patient elevates their arm, that thickened, rigid segment of tendon rubs against the underside of the coracoacromial arch. It's a spatial problem.
It mimics a standard subacromial impingement syndrome perfectly.
To a T, which is why it's so frequently misdiagnosed if imaging isn't obtained early enough.
Okay, so following that formative phase, Uthoff describes a resting period.
Yes, the metaplasia stops. The chondrocytes chill out, the calcium is walled off by a fibrocollagenous border, and it can just sit there.
For how long?
Months, sometimes years. It enters a state of dormancy. The deposit is hard, chalk-like, and structurally stable.
And then suddenly the piece is shattered. We shift from the silent construction site to an active, chaotic demolition zone.
The resorptive phase begins.
What breaks the dormancy?
Honestly, that remains one of the great mysteries of the condition.
We don't know.
We do not fully understand the exact systemic or local trigger that initiates the resorptive cascade, but what we observe histologically is a massive, spontaneous neoangiogenesis.
New blood vessels.
A whole new network of capillaries rapidly invades the fibrocollagenous border of the deposit.
Which restores the blood supply.
Yes, and that breaks the immunological isolation. Suddenly, the body sees the massive chunk of carbonate apatite, recognizes it as non-host tissue, and sends in the cavalry of macrophages.
And that drops us right back into the A&E scenario we started with. The macrophages dissolve the solid chalk into that liquid, toothpaste-like exudate, pressure spikes, the bursa gets inflamed, and the patient is in agony.
Precisely. The mechanical rock becomes a chemical fire.
Once that fire burns out and the macrophages have cleared all the debris, we enter the final act. Uphoff's post-calcific phase.
This is the healing phase. Once the calcium is gone, you are left with a physical void in the tendon.
A crater.
A crater, yes. Granulation tissue rapidly fills that dead space. Fibroblasts migrate into the area and begin laying down new collagen.
What type of collagen initially?
Initially, it's immature type 3 collagen, which is essentially disorganized scar tissue.
Okay.
But over the ensuing months, as the patient moves the shoulder and applies mechanical load to the tendon, that type 3 collagen remodels into mature, longitudinally aligned type I tendon collagen.
Meaning the tendon actually completely reconstitutes itself.
It does. It has a remarkable regenerative capacity. And understanding that life cycle is the fundamental key to treating the disease.
It changes everything.
Exactly.
Yeah.
If you know the tendon has the inherent biological machinery to completely heal itself, your threshold for aggressive structural surgical excision should be incredibly high.
You stop treating the calcification as a permanent degenerative flaw and start treating it as a transient biological event that needs to be managed through its phases.
Could not have said it better.
That biological grounding is phenomenal. But if you're sitting in a busy clinic on a Tuesday morning, you don't have a microscope to look at the patient's tenocytes and figure out if they are undergoing metaplasia.
No, you definitely don't.
You have imaging. So how do we translate Uphoff's cellular phases into something we can see on a screen, and more importantly, use to drive practical clinical decisions?
This is where the marriage of radiology and orthopedics becomes vital. The absolute cornerstone of imaging for calcific tendinitis is still the plain radiograph.
Just standard x-rays.
Yes. Ultrasound and MRI have their distinct roles, of course, but for morphological staging, plain films are mandatory.
When you say plain films, we can't just rely on a single AP view, can we? I mean, the calcium can hide.
A single view is practically useless. You need a dedicated shoulder series.
What does that entail?
A true AP in neutral, internal, and external rotation to profile the different facets of the greater tuberosity. You need an axillary view to assess for any extension into the subscapularis or teres minor, though the vast majority are in the supraspinatus. And a supraspinatus outlet view, or Y view, is helpful to assess the acromial morphology and the subacromial space.
Okay, let's get into the classification systems, because this is where it gets highly practical. When we talk about morphological classification on X-ray, the gold standard is the Gartner and Huck system.
Yes.
They divided these deposits into 3 distinct types based purely on their radiographic appearance.
The genius of the Gartner classification is that it correlates almost perfectly with Uphoff's biological phases. It bridges the gap between what you see and what the cells are doing.
So let's break them down. A Gartner type I deposit.
A Gartner type I deposit is dense, homogeneous, and has sharply defined, clear margins. On an X-ray, it looks like a distinct piece of cortical bone sitting inside the soft tissue of the tendon.
If you're looking at that sharp, dense piece of bone like type I deposit on the film, what is that telling you about the clinical timeline?
It tells you that the deposit is firmly in the formative or resting phase.
It's dormant.
Exactly. It is hard, chalky, and structurally isolated. Biologically, the neoangiogenesis has not occurred. The macrophages have not arrived.
So it's not going anywhere.
No. Therefore, the prognosis for spontaneous resolution in the near term is exceptionally poor.
Right.
If a patient comes in with a type I deposit and they have been in pain for 6 months, you cannot just tell them to wait it out. The biology is dormant. You have to actively intervene to change the course of the disease.
Now let's look at the other extreme, the Gartner type 3 deposit.
Type 3 deposits are translucent, cloudy, and fluffy. They have completely poorly defined, irregular margins.
So if type Y is a sharp piece of chalk?
Type 3 is a cloud of smoke or a smudge of toothpaste smeared across the film. It looks almost ghostly.
And biologically, that ghostly appearance means the demolition crew has arrived.
Exactly. The calcium is actively dissolving. It is losing its structural integrity and dispersing into the surrounding tendon and bursa.
So a type 3 deposit correlates directly with the resorptive phase.
Yes. If you see that fluffy cloud on the radiograph, the patient is likely sitting in front of you in immense pain, but it gives you the ultimate clinical reassurance.
Because it tells you the condition is actively resolving spontaneously.
Spot on. Your job is no longer to extract the calcium. Your job is purely to manage the pain while the body finishes the work.
So type I means intervene, type 3 means support and wait. But of course, medicine is rarely that binary. What about Gartner type 2?
Type 2 is the intermediate phase. The deposit has a dense, homogeneous center, but the margins are starting to blur and become fluffy.
So it's transitioning.
Exactly. It suggests the deposit is just beginning to transition from the resting phase into the early resorptive phase. Clinically, this is the gray area.
How do you manage the gray area?
You have to lean heavily on the patient's symptomatic timeline. Are the symptoms escalating rapidly? If so, they're entering the crisis.
Right.
Are they plateaued? If so, you might still need to nudge the biology along.
We also see the French Arthroscopy Society classification mentioned frequently in the literature. It focuses less on the density of the deposit and more on its topography and shape.
Yes. The French classification divides them into type A, B, C, and D.
Run through those briefly for us.
Type A is sharply localized and homogeneous. Type B is multilobulated. Type C is heterogeneous and dispersed. And type D is actually calcification right at the tendon insertion.
Which is a bit different, right?
Yeah, type D is often more degenerative enthesopathy than true calcific tendinitis.
So how do you use these two systems together in practice? If you have 10 minutes per patient in clinic, does distinguishing between a French type B and type C genuinely alter your immediate management, or is the Gartner system the main driver?
In daily outpatient practice, the Gartner classification assessing the density and the margins is the primary driver of the algorithm. It tells me whether I need to be aggressive or conservative.
And the French system?
The French classification becomes highly relevant if the patient fails conservative management and I'm planning for surgery.
Ah, for surgical planning.
Exactly. Knowing if a deposit is a solitary, well-defined sphere, which is type A, versus a sprawling, multilobulated mass, which is type B, changes my surgical approach. It tells me how wide my tenotomy needs to be and helps me anticipate the resulting tendon defect.
That makes total sense. What about ultrasound? Plain films are great for density, but ultrasound is sitting right there in most modern shoulder clinics.
Ultrasound is an exceptional tool because it provides real-time dynamic information and it allows for immediate targeted intervention.
What are you looking for on the ultrasound?
When you put a high-frequency linear probe over a formative phase deposit, it casts a very strong posterior acoustic shadow.
Because the sound waves can't get through the rock.
Right. The sound waves hit the hard, dense calcium and bounce right back, leaving a completely dark, black shadow beneath the deposit on the screen.
You can literally see how solid it is based on the shadow.
Yes. Conversely, a resorptive deposit, because it is more liquid and paste-like, allows some sound waves to pass through. It casts a much weaker shadow, or sometimes no shadow at all.
And what about the vascularity? You mentioned Doppler earlier.
Yes, if you switch on the power Doppler on the ultrasound, a resting phase deposit will show zero blood flow. It's a dead zone.
Right.
But a resorptive phase deposit will light up like a Christmas tree. You will see marked hyperemia, increased blood flow in the tendon and the bursa surrounding the deposit, visually confirming that massive inflammatory response we discussed earlier.
But there is a massive pitfall here with imaging, is there not?
Oh, huge one.
If a patient comes in with some vague shoulder pain, they get an ultrasound or an MRI, and the radiologist's report comes back stating calcific deposit noted in the supraspinatus. The instinct is to say, aha, I found the pathology. The danger is treating the scan rather than the patient.
That is the single most common error in managing this disease. Absolutely. Studies have shown that up to 20% of asymptomatic adults have calcific deposits in the rotator cuffs that they're entirely unaware
The
of.
20%, that's huge.
It's massive. You might incidentalize a dormant resting phase deposit in a patient whose actual source of pain is an early adhesive capsulitis or maybe a cervical radiculopathy.
So you're treating a shadow on a scan while missing a neck issue.
Exactly. Alternatively, you might see a type 3 deposit and think, I need to extract that pathology, when in reality, the body is already doing it for you.
Yeah.
You must meticulously correlate the imaging morphology with the specific character and timeline of the patient's pain.
If the clinical picture and the scan do not align perfectly, pause before you intervene.
Always.
So let's put all of this into an actionable algorithm. We have a 45-year-old patient. They present with chronic mechanical impingement pain that's been nagging them for 6 months. It is worsening. We get a true AP radiograph, and there it is. A dense, sharply marginated, chalky Gartner-type eye deposit. We do an ultrasound, and it has a massive posterior acoustic shadow and zero Doppler flow. It's structurally solid and biologically dormant. We know it's unlikely to resolve on its own anytime soon. What is the first line of defense? How do we break the dormancy before we even think about needles or scalpels?
The foundational tier of management is conservative. You start with standard non-operative protocols, activity modification, NSAIDs for the baseline mechanical pain, and a highly structured physiotherapy program.
What exactly is the physiotherapist trying to achieve here? They can't massage a piece of chalk out of a tendon?
No, they cannot alter the calcium directly, but they can alter the mechanical environment around it.
How so?
The goal of physiotherapy is twofold. First, to maintain glenohumeral range of motion and prevent secondary adhesive capsulitis, which is a major risk when patients stop moving their arm due to pain.
Right.
Second, and more crucially, to optimize the scapulothoracic kinematics and strengthen the rotator cuff force couples.
So working on the shoulder blade.
Exactly. If you can improve scapular upward rotation and posterior tilt, you increase the volume of the subacromial space.
You essentially create more physical room for that thickened, calcified tendon to glide under the acromion without impinging.
Precisely. It mitigates the mechanical symptoms while we address the pathology.
And we touched on corticosteroid injections earlier for the acute resorptive crisis. Do they have a role in this chronic formative phase?
They do, primarily as a tool to facilitate the physiotherapy. If the patient is in too much mechanical pain to engage in their rehab exercises, a subacromial steroid injection can quiet the reactive bursitis enough to allow them to participate.
But again, you must counsel the patient heavily.
Yes, this steroid will not dissolve the stone. It's a temporary mask for the symptoms, and overuse may prolong the resting phase.
So if standard conservative care and a steroid injection fail to progress the patient after a few months, we need a modality that actively changes the disease state. This is where extracorporeal shockwave therapy, or ESWT, enters the algorithm.
This has become a massive topic in sports medicine and orthopedics over the last decade.
It really has.
The evidence base for ESWT and calcific tendinitis has evolved from exploratory to incredibly robust. It's now a grade A recommendation in many national guidelines. We rely heavily on landmark papers, such as the prospective trials by DeWitt and colleagues, and the comprehensive systematic reviews by Lawrence and his team, which have rigorously evaluated the clinical and radiological outcomes.
When you explain shockwave therapy to a patient, the intuitive assumption is that you're firing sound waves at the calcium to smash it into tiny pieces.
Right.
Like breaking a glass with a high-pitched note or using lithotripsy to shatter a kidney stone. Is that actually what's happening? Is ESWT acting like a sonic hammer?
It's a brilliant analogy, but it's biologically inaccurate for the shoulder. The acoustic energy delivered by orthopedic ESWT devices is simply not high enough to physically shatter the solid carbonate apatite crystals.
If it were, it would probably destroy the tendon.
Exactly. If you tried to use kidney stone lithotripsy energy levels on a rotator cuff, you'd obliterate the tendon tissue. ESWT is not a sonic hammer. It is a biological alarm clock.
I love that. Explain the mechanism of that alarm clock. How do sound waves alter biology?
It relies on a physical phenomenon called cavitation. When high-energy acoustic waves pass through fluid-filled tissues, they create microscopic bubbles, cavitation bubbles.
Okay.
When these bubbles rapidly collapse, they generate intense, localized microjets of energy and microtrauma within the tendon substance.
So you are intentionally causing microdamage to the tendon.
Exactly. That targeted microtrauma serves as a massive stimulus to the dormant tissue. It triggers the release of vascular endothelial growth factor, or VEGF, and other inflammatory mediators.
And what does VEGF do?
It forces the tissue into a state of neoangiogenesis.
Hmm.
You are artificially inducing the formation of new blood vessels into that avascular hypoxic zone we discussed earlier.
Wow. You are hacking the system. You are tricking the body into abandoning the resting phase and actively transitioning into the resorptive phase.
That is precisely what you are doing. By artificially restoring the blood supply, you bring the macrophages back to the site. You initiate the phagocytosis. You are forcing the biological clock forward.
If we look at the literature, particularly the review by Lawrence, there is a very clear distinction made between the types of shockwave machines used. High-energy-focused ESWT versus low-energy radial ESWT.
Yes.
Does it really matter which machine the clinic has?
It matters immensely, and frankly, it is a common reason for treatment failure in the community.
Really?
Absolutely. Radial shockwave devices, which are cheaper and more common in primary care physio clinics, disperse the acoustic energy over a wide area, and the energy drops off rapidly with tissue depth.
Get a shotgun blast.
Exactly like a shotgun blast.
There.
It's great for superficial issues like plantar fasciitis or Achilles tendinopathy, but it struggles to deliver enough concentrated energy deep into the supraspinatus to trigger that robust cavitation effect.
And focused ESWT.
Focused ESWT uses an acoustic lens to converge the energy into a highly concentrated focal point deep within the tissue.
Like a sniper rifle.
Yes. The literature unequivocally demonstrates that high-energy, focused ESWT yields significantly better clinical scores at a much higher rate of complete radiological disappearance of the deposit.
So focused, high-energy ESWT is the gold standard non-invasive intervention. But let's look at the reality of the treatment. It's not exactly a spa day for the patient, is it?
Oh no, it is notoriously uncomfortable. Because you are inducing microtrauma and an inflammatory response, the treatment itself is painful.
And afterwards?
The patient will likely experience an exacerbation of their symptoms for a few days following each session. It typically requires 3 to 5 sessions spaced a week or two apart.
And it's not a silver bullet.
No, it's not. The success rates for complete resolution hover around 60 to 70% in optimal cohorts.
Which means we have a significant cohort of patients who fail. So let's say our 45-year-old patient undergoes 3 sessions of high-energy focused ESWT. They push through the pain, they do their rehab, but 4 months later, they are back in your clinic.
Still in pain.
Still in pain? The mechanical pain is dominating their life. They can't sleep on that side. We repeat the radiograph, and that stubborn, dense Gartner-type eye deposit is still sitting there, completely unchanged.
The alarm clock went off, but the biology hit snooze.
Exactly. They have failed conservative management, but they are terrified of having an operation. We have now reached the crucial intermediate tier of the algorithm, image-guided barbotage.
This is a highly effective, elegant procedure that bridges the gap between the clinic and the operating theater. Barbotage, or ultrasound-guided needling and lavage, is the definitive interventional step for recalcitrant formative deposits.
For our listeners who don't perform this routinely, or for the physiotherapists who refer patients for it, let's break down the exact mechanics. Walk us through the procedure. What are you physically doing to the patient under that ultrasound probe?
Sure. The procedure is performed in an outpatient setting under strict aseptic conditions. The patient is usually in a seated or semi-recumbent position. First, you use the high-frequency ultrasound probe to precisely localize the calcific mass in 3 dimensions within the tendon. You map out a safe trajectory that avoids major blood vessels and the articular cartilage.
And then the local anesthetic.
Yes, you use a generous amount of local anesthetic to numb the skin, the subcutaneous tissue, and critically, the highly innervated subacromial bursa.
And once the track is numb, you go after the deposit itself.
Yes. While continuously visualizing the needle tip on the ultrasound screen, you advance a large bore needle, typically an 18-gauge or 20-gauge spinal needle, directly into the center of the hard calcific mass.
That sounds like trying to push a needle into a piece of chalk.
It often feels exactly like that. You can feel a distinct, gritty resistance as the needle penetrates the deposit.
Wow.
Once you are in the center, you attach a syringe filled with sterile saline or local anesthetic solution. You then apply forceful pressure to the plunger, attempting to inject fluid into the mass.
So you're using fluid pressure.
The goal is to use the hydrostatic pressure of the fluid to mechanically fragment the chalky structure from the inside out.
So you're breaking it apart with fluid pressure. And then what?
You perform the lavage. Using a pulsing motion on the plunger, you inject fluid in and then aspirate it back out. As the pressure breaks the calcium apart, the fluid mixes with the calcific debris.
What does that look like?
When you aspirate, the fluid that comes back into the syringe is profoundly cloudy. It looks exactly like milk.
That's incredible.
You repeatedly flush and aspirate. Sometimes we use a 2-needle technique where one needle pushes fluid in and the other acts as a vent to allow the milky effluent to escape. You continue this until the return fluid is clear or until you can see on the ultrasound that the dense shadow of the deposit has significantly fragmented.
It must be intensely satisfying visually.
Very satisfying.
But after you've traumatized the tendon by jabbing an 18-gauge needle into it repeatedly, what is the post-procedure protocol?
As you withdraw the needle, the final step is to deposit a dose of corticosteroid directly into the subacromial bursa.
Why is that?
The physical trauma of the needling, combined with any residual calcium that escapes into the bursa during the lavage, will trigger a massive inflammatory flare over the next 48 hours. The steroid mitigates that reactive bursitis.
Okay, so they go home.
The patient goes home, rests for a few days, and then aggressively restarts their physiotherapy to maintain the range of motion as the tendon heals.
Now let's look at the evidence base for barbotage because patient selection is everything here.
Absolutely crucial.
If you look at the Cochrane reviews and the broader literature, there is a very specific morphological sweet spot for success. The data suggests that barbotage is most effective for deposits that are greater than 15 millimeters in diameter and exclusively in the formative Gartner-type eye phase. Let's unpack that.
Yeah.
Why that specific 15 millimeter size threshold? What happens if you try to lavage a 10 millimeter deposit?
It comes down to the simple physics of the procedure and the risk-benefit ratio of the iatrogenic trauma. To successfully perform a lavage, you need to reliably place an 18-gauge needle into the absolute center of the mass. And you need enough physical volume within that mass to generate hydrostatic pressure without the fluid simply blowing out the sides into the healthy tendon.
Right.
If a deposit is only 8 or 10 millimeters, it's technically much harder to target perfectly. More importantly, attempting to forcefully lavage a small deposit often causes disproportionate collateral damage to the surrounding healthy parallel collagen fibers of the rotator cuff.
You end up tearing up normal tendon for a very little gain.
Exactly. Furthermore, deposits smaller than 15 millimeters have a statistically much higher rate of successful resolution with non-invasive ESWT. So the risk of needling is not justified.
But a dense, massive 20 millimeter rock sitting in the tendon is an excellent, stable target for an 18-gauge needle, and it's unlikely to respond fully to shockwave. And the second half of that rule, only in the formative phase. If a patient comes in with a massive 20 millimeter Gartner type 3 deposit, they are in the resorptive phase, the calcium is already a milky paste, and they are in agony. Intuitively, one might think, great, it's already liquid, let's just stick a needle in and suck it out for them. Why is that contraindicated?
It seems logical, I agree, but it is biologically unnecessary and clinically cruel.
Cruel.
Yes. If they're in the resorptive phase, the body has already achieved what the needle is trying to do. The neoangiogenesis has happened, the macrophages are eating the calcium, and the deposit is already dispersing. The surrounding tendon and bursa are in a state of hyperacute inflammation.
So it's very sensitive.
Extremely sensitive. Sticking a large bore needle into that friable, angry, hypervascular tissue will cause excruciating pain, even with local anesthetic, and it risks significant bleeding and further damage to an already compromised tendon structure.
The body is already doing the barbotage for you. Don't interrupt it.
Exactly. Barbotage is designed specifically to mechanically disrupt the hard, stubborn, dormant deposits that the body is ignoring.
I want to push back on the ultimate efficacy of barbotage, though.
Go ahead.
If a deposit is 20 millimeters across and rock hard, it represents a substantial structural mass. Even with a perfect two-needle technique, you are never extracting 100% of that calcium. You are leaving debris behind.
That's true.
Is barbotage reliably curing the patient, or are we simply buying time? Are we just poking holes in a rock, reducing the volume by 30%, and delaying the inevitable trip to the operating theater?
That is a very valid critique, and frankly, it is a point of robust debate at shoulder conferences. You are correct. We rarely extract every single crystal of calcium. But clinical success doesn't require 100% radiological clearance.
It doesn't.
No. The efficacy of barbotage relies on two distinct mechanisms. First, the mechanical decompression. Even if you only aspirate 50% of the mass, you have significantly reduced the volume of the space-occupying lesion.
Which immediately dramatically reduces the mechanical subacromial impingement.
Yes, so the mechanical pain drops instantly. But the second, and arguably more profound mechanism, is biological.
Ah, the alarm clock again.
Exactly. The physical trauma of aggressively needling the dormant tendon creates a localized bleeding response. It disrupts the vascular envelope around the deposit. Just like ESWT, the needling itself acts as a massive trigger for neoangiogenesis.
You physically break the dormancy and force the transition from the resting phase into the resorptive phase.
Yes. For a vast majority of patients, and the Cochrane reviews support excellent medium-term outcomes. That combination of volume reduction and biological triggering is enough to permanently resolve their symptoms.
The body finishes off the remaining 50% that you left behind.
Precisely. However, for a specific subset of patients, those with massive, multilobulated, multifocal French type B deposits that encompass a huge footprint of the tendon barbotage may indeed be a temporizing measure.
So if the structural alteration to the tendon is too severe, the biological reset isn't enough.
Right. And that leads us to the final threshold.
The end of the line. Section 6, the surgical threshold. Our patient has done the physio, they failed the high-energy shockwave, they underwent a barbotage which temporarily reduced their pain, but 9 months later, the pain is back, the shoulder is weak, and their quality of life is severely impacted. We are heading to the operating theater for arthroscopic excision.
Surgery is the absolute last resort in the algorithm, but when conservative and intermediate measures have been exhausted, or if a deposit is so massive it's causing imminent structural tearing of the rotator cuff, arthroscopy is highly successful.
Let's walk into the theater. You perform a standard posterior portal diagnostic arthroscopy. When you put the camera into the subacromial space of a patient with severe recalcitrant calcific tendinitis, what does the gross pathology actually look like on the screen?
Well, initially, you often cannot see the tendon at all.
Really? Why not?
The subacromial space is usually obliterated by a thick, angry, hypertrophic bursa. You have to spend a significant amount of time with the motorized shaver performing a meticulous wide bursectomy just to clear the view.
You have to clear the brush before you can see the forest?
Exactly. Once you finally establish a clear visual of the bursal surface of the supraspinatus tendon, you're looking for specific visual cues.
Because the calcium is usually interstitial, right? It's buried inside the tendon tissue. It's not just sitting on top.
Exactly, it's intertendinous. So you look for a focal area of intense hyperemia, a cluster of angry red blood vessels.
Like a hot spot.
Yeah. The tendon in that area often looks distinctly swollen or convex, bulging upwards into the subacromial space. We often refer to it as the strawberry sign.
The strawberry sign.
Yes. And in severe cases, the overlying tendon fibers have thinned out so much that you can actually see a pale white or yellowish patch of the calcium mass glowing just beneath the surface.
And if it is entirely deep within the substance of the tendon and there's no obvious white patch, how do you locate it without just blindly cutting into the cuff?
You use a standard 18-gauge spinal needle as a probe. You systematically puncture the tendon in a grid pattern over the suspected area, correlating with your preoperative ultrasound or MRI mapping.
And what does it feel like?
When the needle hits the deposit, you feel a very distinct, sudden grittiness. It feels like pushing a needle into a bag of wet sand.
And once you find it, how do you get it out?
Once localized, you use a scalpel or an arthroscopic blade to make a precise, longitudinal incision through the superficial tendon fibers.
Longitudinal, so in line with the fibers.
Exactly in line with the direction of the collagen bundles to minimize structural damage. As soon as you breach the capsule of the deposit, the pressurized calcium erupts into the joint space.
The Fabiano-Storm effect?
Yes. It is arguably one of the most visually spectacular moments in orthopedic surgery. A massive plume of white, chalky debris billows out into the clear arthroscopic fluid. It literally looks like a blizzard inside the shoulder.
Wow.
You then use a small curette or a motorized shaver to gently debride the cavity, expressing as much of the paste and chalk as possible.
It must be incredibly satisfying for the surgeon. It's the high-stakes, highly technical orthopedic equivalent of popping a massive, stubborn pimple. You finally see the offending pathology evacuate.
It is immensely satisfying. But that satisfaction is immediately replaced by the most complex, anxiety-inducing decision of the entire procedure.
The cuff defect controversy.
Yes.
You've just aggressively hollowed out this massive volume of calcium from the middle of the supraspinatus tendon. You are left with a crater, a physical void in a major load-bearing structure. Do you repair that resulting defect with sutures, or do you leave it open and let it heal on its own?
This is the ultimate intersection of surgical art and biomechanical science. And to navigate it, we lean heavily on the evidence base, particularly the comprehensive evaluations by researchers like Balk and colleagues who looked specifically at the outcomes of arthroscopic treatment regarding this exact dilemma.
Let's debate the two approaches. The historical conservative approach was the scoop and leave method.
Right.
You make the longitudinal split, scoop out the calcium, wash it out, and you leave the tendon alone. You rely entirely on Uthoff's final post-calcific remodeling phase, the granulation tissue, and the type 3 collagen to organically fill the void.
Yes, and the rationale for scoop and leave is powerful. The Balk paper and subsequent studies highlight that the single most devastating complication following surgery for calcific tendinitis is not a re-tear. It's severe post-operative adhesive capsulitis or frozen shoulder.
Why is that?
The surgical trauma of excising the deposit inevitably triggers a massive inflammatory cascade in the joint capsule. If you then perform a formal rotator cuff repair, placing suture anchors, tying knots, and tensioning the tendon, you are obligated to put that patient in a strict immobilization sling for 4 to 6 weeks to protect the repair.
And immobilizing an acutely inflamed shoulder for 6 weeks is a guaranteed recipe for a rock-solid, stiff joint.
Exactly. You trade a painful calcium deposit for a shoulder that cannot move past 45 degrees for a year.
That's a terrible trade.
Terrible. By leaving the longitudinal split open, you allow the patient to begin immediate active-assisted mobilization on day 1.
So the movement is key.
The movement prevents capsular fibroplasia, it prevents the stiffness, and mechanically stimulates the fibroblasts to begin that collagen remodeling phase.
That sounds like a definitive argument for leaving it alone, but I have to challenge the biomechanics of that. If the deposit was massive, say 20 or 25 millimeters, and you hollow it out, you have essentially created a massive iatrogenic rotator cuff tear. If you leave a gaping 2-centimeter crater in the supraspinatus footprint, the mechanical tension on the remaining anterior and posterior leaves of the tendon will be immense.
That's the counterargument, exactly.
Are you not risking the propagation of a massive structural cuff tear the moment they lift a kettle?
Yes, and that is why the decision must be made dynamically, in real time, based on the size and the integrity of the remaining tissue. The modern consensus, guided by the literature, is that it depends entirely on the residual defect.
So what's the threshold in theater?
If you make a small inline split, remove the calcium, and the anterior and posterior leaves of the tendon naturally fall back into close approximation with minimal tension, you leave it alone. The biology will bridge a small gap.
But what if it's a massive void?
If the removal leaves a full thickness, gaping void greater than a centimeter, or if the overlying tendon tissue is incredibly degenerate, frayed, and delaminated, you have structurally compromised the force coupling of the rotator cuff. You've created a biomechanical hazard. In those cases, you must repair it.
How do you repair it without over-tensioning it?
Often, we use simple side-to-side margin convergence sutures, just bringing the edges of the split together with heavy, non-absorbable sutures to restore the continuity of the tendon without anchoring it down to the bone.
Oh, I see. So you just close the gap.
Yes. This restores the structural integrity, but allows for slightly faster rehabilitation than a formal anchor repair. However, if the deposit was situated right at the bony footprint and its removal detached the tendon from the greater tuberosity, you have no choice but to use a suture anchor and perform a formal transosseous equivalent repair.
And if you do that, you accept the high risk of postoperative stiffness.
Yes, and you counsel the patient that their rehabilitation is going to be a protracted 6 to 9 month journey. You are constantly balancing the mechanical risk of a propagated tear against the biological risk of severe stiffness.
The masterclass in this surgery is not just finding the calcium, it's extracting the maximum amount of pathology while inflicting the absolute minimum amount of structural iatrogenic trauma on the tendon architecture.
That is the essence of it, yes.
It's a phenomenal synthesis of cellular pathology, biomechanics, and surgical technique. We have journeyed all the way from the silent hypoxic genesis of the calcific deposit in the critical zone of Codman through the agony of the macrophage-driven resorptive crisis.
It's quite the journey.
We've navigated the nuances of the Gartner and French imaging classifications, debated the biological alarm clock of shockwave therapy, dissected the exact physics of a 15-millimeter Barbotage threshold, and finally navigated the high-stakes biomechanical tightrope of arthroscopic excision and cuff repair.
It is a condition that demands immense diagnostic patience and highly tailored interventions. You cannot force the tendon's biology to comply with your schedule, but if you understand the phases, you can expertly guide it.
Let's crystallize this entire journey for our listeners. If you are driving or prepping for a clinic and you are trying to synthesize everything we've discussed, here are the core, actionable, clinical pearls to anchor your practice. First, the counterintuitive nature of pain.
The most agonizing hyperacute presentation is almost always the resorptive crisis.
Right. It's a self-limiting biological demolition phase that demands urgent symptomatic relief, aggressive validation of the patient's pain, and a steadfast avoidance of premature surgical excision.
Absolutely. The pain is the cure in progress. Do not interrupt it.
Second, decoding the scans. Do not treat the radiologist's report. Treat the morphology. Look for the Gartner classification on plain films. Dense, sharply defined, chalky deposits. Type I are dormant, formative, and stubborn. They require active intervention. Fluffy, translucent, ghostly, toothpaste-like deposits. Type 3 are actively resorbing and require supportive patience.
Correlating that morphology with the patient's symptomatic timeline is the most important diagnostic step you can take.
And third, the interventional threshold. When stepping up the algorithm, remember the Cochrane data. Image-guided barbotage is highly effective, but its success is heavily weighted towards formative, type I deposits that are greater than 15 millimeters in diameter. Attempting to lavage smaller deposits or attempting to needle a hypervascular resorptive phase deposit risks unnecessary iatrogenic trauma for minimal clinical gain.
I would agree entirely. If you master those three distinctions, understanding the pain paradox, staging morphology, and respecting the 15 mm interventional threshold, you will confidently solve the vast majority of the clinical dilemmas you face with this condition.
If this deep dive has clarified your clinical approach today, or if you have finally figured out why that one patient's shoulder pain spiked right before it disappeared, please take a moment to rate the show, subscribe, and share Deep Dive Ortho with your colleagues in the department.
It's been a great discussion.
But before we sign off, I want to leave you with a final, provocative thought to ponder regarding the natural history and the ultimate etiology of this disease. We have established today, in great detail, that the human body possesses the inherent complex cellular machinery, the neoangiogenesis, the targeted macrophages, the fibroblastic collagen remodeling, to completely and spontaneously resorb these deposits and heal the tendon perfectly.
It's an incredible system.
The systemic machinery works. So if the body has the profound capability to recognize the calcium, dissolve it, and repair the damage, what fundamental error occurs that allows it to build the deposit in the exact same tendon or perhaps the contralateral shoulder 5 years later? What is the underlying systemic or genetic vulnerability that repeatedly overrides the body's own immune surveillance? Why does the system fail before it succeeds?
That is the ultimate unanswered question in tendinopathy research, and it is certainly a topic that warrants its own extensive deep dive in the future.
Indeed it is. Thank you for joining us as we unpacked the evidence and the clinical realities today. Keep questioning the consensus, trust your clinical exams, and we will see you on the next deep dive.